Thank you for inviting me to this Multiple Myeloma Hub symposium. We at the COMy Congress are extremely grateful for the Hub for organizing this nonprofit activity. And I'd like to congratulate you and Sagar for the flourishing Multiple Myeloma Hub activities. This is really very fascinating initiative. So you've given me for the next few minutes or so the very hard task of trying to answer the question, does cure have a different meaning in multiple myeloma? I'm not sure I have the right answer, but I'll try to provide some data from the available research evidence on how to approach this question. These are my disclosures. Just for the sake of introduction, this is an active young businessman with myeloma. The question is, does cure have a same meaning for him compared to this older but fit gentleman, but also compared to this older but definitely frail and fragile multiple myeloma patient? So you would guess the question is quite difficult, especially if you consider the traditional vision of cure we have. And I think in the hematology field, chronic myeloid leukemia is really the disease model, I think, for cure, where thanks to the advent of TK inhibitors, these patients can enjoy, I think, similar survival to what you would expect from the life expectancy of someone without such disease. In the field of myeloma, I think we are still far from this definition, which is reaching, the life expectancy of a normal individual. Although already in 1991, and we owe a lot to Dr. Barloghi, he asked the question about whether we're going for a cure in multiple myeloma at a time where I think the only available options were about conventional chemotherapies. But this has raised a lot of debate actually within the myeloma community at this time. And you see these editorial reviews, whether this is reality, whether this is hype. And then Dr. Rajkumar and the Mayo Clinic team came with the concept of cure versus control. Still, Dr. Barloghi persisted. And thanks to the total therapy, I think he was able to show that at least a small proportion of patients over the long term is capable of achieving some cure, which I now would call functional or operational cure. And this has been shown progressively over time by adding the new so-called novel agent, which are now standard of care, I think. And part of these efforts to try to define the cure was the findings that actually those patients achieving a complete remission, according to the historical definition of complete remission, are likely those patients who are going to achieve the best outcome. And if you look after 10 years of follow-up, there's definitely 25 maybe % of the patients who are enjoying a sort of a plateau curve. And that has actually prompted several colleagues, especially Dr. Ray Pauls, who was the first time, as far as I was able to look, and this was brought to my attention by Professor Harousseau, actually, in an abstract from ASH, highlighting and using the semantic of operational cure. And today, according to different investigators, especially Dr. San Miguel and colleagues, it was highlighted that the definition of cure or functional cure is likely about those patients who are in complete remission for more than 10 years. However, later data could also establish that CR by itself is not sufficient, but it's about sustainability. So you need to have sustained CR. And in the study by Dr. Barloghi's group, it was about more than 2 years. And this has been further emphasized and brought into a higher level, introducing the concept of MRD negativity. So whenever you are able to dig deeper in terms of response, actually, it's slightly better to predict the longer outcome. And this is the seminal contribution from our colleagues in Spain, highlighting that the value of CR relies on the MRD status. And achieving MRD negativity is likely the best predictor of longer survival. When looking into the modern treatment approaches, I think the IFM 2009 trial data published now 4 or 5 years ago were quite convincing, because this is the trial which tested an auto-transplant arm with an induction RVD, lenalidomide, bortezomib, dexamethasone, followed by auto consolidation, len maintenance, versus, I would consider, a non-transplant, but still a very active, very potent state-of-the-art therapy with lenalidomide, bortezomib, dexamethasone, followed by maintenance. And Professor Ave-Loiseau has assessed MRD as part of this protocol, and you can appreciate here the very elegant PFS curves when it comes to looking into MRD negativity at a very high threshold, 10-6, and that was published by Dr. Perot in Blood a couple of years ago. And actually, the treatment by itself can have an impact on the interpretation of the MRD value. But at some point, if you are able to achieve a very deep MRD, actually, irrespective the way you can achieve this, this is definitely good news for the patient. And these conclusions, these results were further demonstrated in a very amazing set of data, meta-analysis of 14 studies, more than 1,200 patients. And you can see these blue curves here highlighting the value of MRD negativity on progression-free survival. When you look into the concept of sustainability of MRD, I think the conclusions can become even more appealing, because although this is a relatively smaller study, but still, when you look into the patient who were 24 months with 24 months of sustained MRD negativity, then definitely you can see these fantastic survival curves. Very recently, I think this was a couple of months ago, we have seen a publication in Blood about the value of MRD negativity in the high-risk cytogenetics patient, because we're all familiar with the baseline characteristic for defining high risk. And now it is proving that we do have a dynamic tool to define high-risk disease. And definitely MRD negativity, if you are able to achieve it, and I think now with all the novel combinations, this is going to be a more frequent probability, well, definitely achieving undetectable MRD would allow to overcome the dismal prognosis of the transplant-eligible patient with high-risk cytogenetics. And there was also a very recent study from the group of Dr. Nikhil Munshi at Dana-Farber, looking into 44 studies. And if you look into the association of MRD negativity and progression-free survival in different subgroups, actually, all the results you can see here on this forest plot on the left-hand side, everything is in favor of the MRD negativity, whether you consider the threshold, the cytogenetic risk, the method for assessment, the depth of clinical response, or the measurement of MRD status pre-maintenance. So the factors that can impact are definitely the sensitivity, the type of treatment, the prognostic factors, but also we should not neglect the issue of age. And very recently, and this is really new, the value of MRD negativity was also shown not only in the frontline setting, as I have been presenting since the beginning, but also in the relapse setting. This is another JCO paper by Dr. Ave Loiseau on behalf of many international investigators looking into the famous Pollux trial. For instance, this is a trial which allowed the approval of daratumumab, lenalidomide, dexamethasone, and actually those patients achieving MRD negativity at 10-5, this is the recommendation of the IMW group, are actually those patients who are enjoying really a very nice long-term, progression-free survival. And when you look to the sustainability, the results are even better, whether you consider 6 months, but also 12 months. So definitely MRD negativity, sustained MRD negativity are really now the targets we would like to achieve. And we believe that now with all the available treatment options we have in hand, we can clearly increase the number of patients who are in deep MRD negativity, but also sustained MRD negativity. And if you look, for instance, into these novel induction regimens prior to transplant, like the DARA-RVD, daratumumab, len, bortezomib, dexamethasone, like in the Griffin trial, you can appreciate that up to more than 60% of the patients are able to be in a MRD negative response after 12 months. So this is really a very good start for maybe achieving operational cure. In addition, I think we can further refine this concept of MRD negativity and cure by integrating PET-CT, because obviously myeloma is a bit more difficult disease compared to leukemia, where looking into the leukemic cells in the blood may be sufficient, because we do have the extramedullary disease, we have the patchy involvement, we have the technical issues with the samples. So definitely PET-CT can provide some additional information. And obviously, I'm sure that at some point the IMW will reconsider the definitions and will rework, I think, on further refining this issue of MRD negativity, whether looking to the threshold, whether combining with PET scan negativity, and so on. So in conclusion to the question, whether can we achieve a cure, I would say definitely we are going, hopefully in the near future, to have an increased number of myeloma patients who are clearly considered in sort of a functional or operational cure, provided that we are able to achieve very deep MRD negativity in these patients, but also maybe a negative PET scan. And this is true for the young patient, but also for the elderly patient. And I think many of you are really very familiar with this traditional slide about the goals of therapy. And this is really still very relevant today, although it was published by Dr. Peva 6 years ago in Blood. With this, I'd like to thank you for your attention, and we'll take your questions during the panel discussion. Thank you very much.